So I want to introduce you to Professor of Surgery at the University of Michigan, Dr. Wilkins, who specializes in masculinizing and feminizing breast surgeries. Go ahead, Dr. Wilkins, take it away.
Thanks, Lou. Good morning or good afternoon, everyone, depending on where you are. I'm going to take a leap of faith here and try sharing screen. Let's see. Let's try that and that. And wow, I actually made it work. It's a miracle. As Lou mentioned, I'm going to spend a few minutes talking about transgender breast surgery, both masculinizing and feminizing. This is something I've been doing for a number of years. I came back to it actually about 5 years ago, mainly because of some changes in responsibility, in our section, but it's been a big part of my practice now for about 5 years. And it's also my favorite part. And here's why. This, for many, if not most of my transgender patients, our transgender patients, it's really transformational. And there are very few other reconstructive surgeries that we do that can be characterized that way. This literally does change many people's lives. And I hear this pretty much every week when I talk to our post-op patients who are up to 6 months out. And so if you're a surgeon, this is about as good as it gets. You feel like you're really making a difference. And people ask me why I do it. Well, that's why I do it. So this is something that we've actually studied as well. There are now good survey instruments, questionnaires that measure quality of life, body image, psychosocial well-being, and we've actually been able to measure significant gains and significant reduction in gender dysphoria after the surgery compared to pre-op measures. It's actually measurable and quantifiable. We don't necessarily just see it on an anecdotal basis. It's something that we can measure with science. So of all the transgender surgeries, top surgeries appear to be gaining utilization or are more commonly used now compared to 10 years ago, really above and beyond other gender affirming operations. And of these, masculinizing top surgery has shown the biggest increase. This is for a number of reasons. Most commonly, though, most notably, there's been a significant increase in coverage by payers for these operations. And most recently, and a little bit belatedly, actually the Veterans Administration hospitals, Department of Veterans Affairs has now indicated they're going to start covering these operations as well. A little late, but better than never. So there's increasing coverage for this. And I think that's a big reason why we're seeing and doing more of these operations. So most of you, if not all of you, are familiar with the WPATH standards for gender affirming surgery and for hormonal treatment as well, the World Professional Association for Transgender Health. We try to follow these standards where we can, not because we're particularly dogmatic about it, it's just because these are a pretty good idea to make sure that people are ready for surgery. Surgery is pretty irreversible, so you want to make sure you're doing the right thing at the right time. And you can see the criteria here. Documented gender dysphoria, obviously, as with any operation, the ability to make an informed decision and to consent. Age of majority is changing a little bit. Certainly, to give one's own consent for surgery, you have to be 18 legally, but we're doing more and more of these surgeries on people under 18 as well, with consent from parent or guardian. If there are other medical problems going on or mental health issues, those need to be fairly stable in order for the surgery to be done safely. Finally, oh, we're getting a little feedback there, I think. Can everybody make sure you're on mute, if you would? Thanks. And so for those taking feminizing hormones, it's best to be on those for at least a year before you have top surgery, because you will get some breast development with the hormones, and we want to have that sort of maximized before we start making changes in breast volume. So obviously there are two basic types of top surgeries: masculinizing, which just about always means mastectomy, and feminizing, breast enlargement or breast augmentation. And so I'm going to spend the first few minutes talking about the masculinizing operations. So this is interesting to me that more than any of the other operations done for male or female trans, non-binaries, genderqueer, this is the operation that is most sought by people. For those essentially trans males and also non-binaries, I think this includes both, and this is from the 2015 Transgender survey. A fifth, 21% of folks had had the surgery, and half of the folks hadn't had it but wanted it someday. So 3/4 roughly of people in this category have either had it or want it someday, and less so with some of the other masculinizing surgeries. So there are a number of different techniques for this. Just click on one thing there, thank you. And essentially these can be grouped into either what are called single scar or two scar or double scar techniques. And I'll go into this here in just a moment. Under the single scar, the perioreolar semicircle keyhole, whatever you'd like to term it, and then the concentric circle or donut technique. The two scar technique is pretty standardized with some variations, with a scar along the fold under the breast, with or without nipple grafting, depending on what people want. So single scar, the technical term is perioreolar, or it can be inframammary, meaning the incision is either around the ovula or areola, if you prefer, or in the fold under the breast. And essentially, this is simply excision of the breast tissue, often using, in part, liposuction, but also direct excision, meaning without a better term, cutting out the breast tissue. And as we'll talk about in a minute, you know, it's a good technique, but picking the right people and making the right decision with them is particularly important with this operation. And the way we decide is how much loose breast skin there is or will be once we remove the breast tissue, because we don't want redundant skin or sag. If you want the technical term, we call it ptosis afterwards. That's not something really anybody wants. And so obviously the advantage with this approach is minimal scarring. You have a small scar around the areola, or a slightly larger scar, but still well camouflaged in most people, where the fold under the breast used to be. And you know, I'm a plastic surgeon, I'm trained to hate scars, and I like operations that produce less scarring. But, and there's some pretty big buts here, you cannot remove excess skin or lift the breast. And frankly, most of the patients I see have that extra skin. They have some sag. And the single scar does not remove that excess skin much, if at all. For people looking for a more masculine appearance, this operation, the single scar or periareolar, does not downsize the areola. It can, but that's a fairly risky proposition with this operation. Nor can it move the nipples up and out into a more male configuration. Does not do that well. Issues with rippling or contour irregularities are more common with this approach compared to the double scar. Again, because you're not taking out extra skin, you're not tightening the skin, but also for the surgeon, it's a little bit harder to get a nice, smooth removal of the breast tissue, to have a very consistent thickness of padding under the skin from top to bottom. And so, partly because of that and because of nipple areolar positioning issues, these operations have higher revision rates compared to the double scar. And so, people go, well, if I need a second operation, I'll have a second operation. Well, that's good, except payers rarely cover revisions. We've had a few instances where we could get coverage for a revision, but generally speaking, that's really tough to do. And so if people need revisions with this operation, unfortunately, often that ends up coming out of their own pocket. And so we try to stay away from revisions, avoid them as much as we can, which unfortunately means that we do fewer of the single scar than we do the double scar. And I think that's common for pretty much every plastic surgeon doing these operations. Now, the next step up as far as removing skin is a concentric circle technique. Some people call it a donut mastopexy, where you take out a strip of skin around the areola and then sew all that together to tighten the skin. It gives you a little bit of a lift. It also allows you to reduce the diameter or width of the areola, but it gives you a fairly limited opportunity to remove skin. But you see pictures on the right. The upper one is the donut mastopexy, and the one on the bottom includes the donut plus some skin darts on either side to further lift or tighten the skin. So compared with the double scar, this involves less scarring, which is good, and it does remove some excess skin, which is also good. The problem is that it can't remove more than a little bit of skin excess. If you try to do more than that, then the nipple will lose its blood supply, and the chances for nipple loss are higher. And even with these additional skin removals, you still cannot move the nipple up very much or out very much. So if you want to do a major repositioning, this is not going to work for you. And overall, the single scar procedures, both these and even just the periareolar or under the breast technique, do have higher rates of nipple loss because of compromise of the circulation to the nipple. And again, higher revision rates with these, where the surgeon just could not get out enough skin to tighten it and get the nice smooth appearance that people want. And again, there are issues with getting revisions paid for. And I hate to even bring that up, but unfortunately, in this day and age, that does determine a lot of what we can and can't do as surgeons. So this is the one that I, and I think pretty much all my colleagues, do the most, because most of the people I see wanting masculinizing top surgery, first of all, aren't thin, and they don't have small breasts, and they have some sag. And so in people who are carrying some extra pounds and have substantial breast size and have any more than minimal sag, this is the preferred technique. And so as you see in the figure there on the right, ultimately you end up with scars that travel from just off the midline and either go up into the armpit up high along the edge of that pectoral muscle, or in bigger folks where they have a roll in their armpits, the breast sort of transitions into a roll of fat. We may actually take that scar further into the armpit to try to get at least some improvement in contour adjacent to that roll. And as we'll see in a minute, that's an issue with heavier folks. And with 2/3 of our adult population being heavier, this is something that we deal with pretty much weekly. The nipples are actually removed without going into all the gory details, but they're removed as skin grafts. They're downsized. Our standard diameter is about 1 inch in diameter. And then they're put back on sort of up and out into a more masculine configuration. And that is if people want the nipple grafts. I have a number of clients who just go, don't want the nipple grafts, or I'd like nipples, but I'm going to have them tattooed on. All of that is fine, as long as you tell me beforehand so I can follow your preference. It's absolutely fine. But most clientele do want the nipple grafts, and so we put those back on, albeit in a smaller, lower diameter form, up and out in the more masculine configuration. So advantages of the double scar technique, or if you want to be technical about it, you can call them simple mastectomies with or without the nipple grafts. So if people have a lot of excess skin, if they have sag or ptosis sounds better, but if they have a lot of that, you can remove the excess skin and get a smoother, tighter appearance. And again, you can downsize nipples and position them into a more masculine location. And also in folks carrying those extra pounds, we can do at least a little bit of skin contouring in the underarm area. That's not really the breast, but we don't want an abrupt transition from the flatter chest into the extra skin and fat under the arm. So we can do a little bit of sort of mini body contouring at the same time. So downsize, well, obviously more scars. And I'm sure everybody in the virtual room here either knows somebody who's had this done or seen pictures on the internet. And these are not, in all honesty, subtle scars. They do fade with time, but they are always going to be there. You do see people who have some, not necessarily keloiding, that's actually quite rare, but some people develop thicker scars because that's their innate God-given scar healing tendency. And so, these are not subtle scars. The other thing I see is in people of color, when we do the nipple areolar grafts, you can see some loss of the natural pigmentation in the nipple or the areola, namely in people with darker colors of nipple and areolar pigment. You see some loss of that pigmentation and some little spots of pink because that's the way it heals in those areas. This probably happened, for example, in African Americans. I see this to some degree in probably 1/4 to 1/3 of patients. It's actually quite common. Thankfully, it doesn't seem particularly bothersome to most people, but it's the one downside that I see, the biggest downside for the two-scar technique in people of color. We and others have tried tattooing in those lighter pink areas. It takes the pigment, the tattoo pigment, okay, but not great. I think tattooing is sort of an imperfect solution to that problem. One more thing that people ask about, I don't have it here, but that's the loss of sensation. This matters a lot to some people, doesn't matter a lot to other people. But with both the single and the double scar techniques, you do see in most people, I would almost say everybody, at least some loss of skin sensation, skin feeling, if you will. You see it more in one operation versus the other. In my experience, and I've done several hundred of these, I guess, I have not seen a big difference. Some people have permanent numbness forever in the nipple area. Some people get back a lot of sensation. I wouldn't call it normal, but darn near. And everybody else is kind of in between those two extremes. It's kind of a bell-shaped curve. You don't know until you're a year and a half out how much you're going to get, because the nerves going back in do it very slowly. They say about 1 millimeter a day. And so you have to wait quite a while to actually answer the question of how much sensation you're going to get back. But I would expect at least some loss of sensation. Not ideal, but it's the price that we pay for taking out this amount of breast tissue, because the skin nerves travel through that breast tissue. So, numbers. These are generally in the neighborhood of 3 hours, and of course you go to sleep for this. We generally do pretty much all these as outpatients these days, unless the patient has some medical issues that we want to watch overnight. So if people have brittle diabetes, high blood pressure troubles, or other medical issues, we may keep them overnight. But in my practice, that's less than 5%, 5 people out of 100. You do have drains after these operations. They are a necessary evil. If you hear horror stories about drains, don't believe them, because the drains we use nowadays are very small and they slide out very easily, sometimes too easily if they come out prematurely, which occasionally happens. But they generally stay for a week or two to prevent the buildup of fluid inside the wound while the wound is healing. Doesn't necessarily prevent bleeding, but people do secrete, in essence, blister fluid into wounds after surgery, and we don't want that to build up and put pressure on the overlying skin, potentially compromising that skin. Don't want folks driving for 3 weeks after surgery. That's a tough one. And no physical work or working out for 4 weeks. Now, does that mean everybody's out of work for 4 weeks? No. People who have desk office kind of jobs sometimes go back sooner. On the other extreme, people have very physically demanding jobs. They lift and carry and push and pull at work. They may be out for 6 weeks, occasionally longer. As long as people don't go back too soon, I have no problem with people staying out a little bit longer, as long as they're not putting themselves in danger. The other thing is that with both the single and double scars, we want people to wear compression for 4 weeks after surgery. For the first week after, in my practice, you're wrapped up in an ACE wrap that just stays on. But then when you come back to clinic at a week out for your post-op visit, we want you to transition to either a spandex or elastic vest, or a spandex t-shirt, like, for example, one of the Under Armour or equivalent compression t-shirts like the athletes wear. Those tend to work pretty well. But some kind of compression for 4 weeks, again, to prevent fluid buildup, these so-called seromas, or collection of serum, blister fluid in the wound. All right, let's see. Other things to remember. Well, already talked about sensation. Symmetry. People sometimes go, I want them exactly the same. I get it. I would like to have them that way too, but the problem is that either before or after surgery, no one is perfectly symmetric. Mirror image symmetry, unfortunately, in nature and after surgery, is a myth. I have not had to reoperate on anybody for asymmetry, but still, there will be some subtle differences between the two sides. And everybody goes, yeah, I know that. Well, sometimes people want them perfectly symmetric, and I get it. It's just that in this life, that is unfortunately not possible. Body contouring. This is the issue I was talking about before with some of our patients carrying a few extra pounds, that we do some body contouring in the armpit, but I can't take away all of that role. And so it's just something that we mention to people beforehand. The best way to take care of that is weight loss, and nobody wants to hear that, but it is true. The other thing to think about is that no mastectomy removes 100% of the breast tissue. Usually 95% plus, but not 100%. It's literally physically impossible to do that. And so For the rest of their lives, these patients need to do monthly self-exams and also have provider exams, doctor or PA, nurse practitioner exams, probably yearly, starting at least at age 35 or 40. Can't get a mammogram because there's not enough breast tissue there left to see on a mammogram, but still something to be aware of. The operation certainly does significantly reduce the risk of breast cancer, but not completely, not quite 100%. So just something to be aware of. So a couple of pictures. This is a thinner patient. And in this particular case, we stopped the incision sort of at the front of the armpit. Scars are looking pretty good, but he is still fairly close out. I think this was taken 2 or 3 months out from surgery. Takes a year for that pink color to go away. It usually does. During that first year, if you're going shirtless outside, you need to make sure you're wearing sunscreen on those scars so they don't darken permanently in the sun, which they can do. But this guy has a really good physique, and this worked very nicely for him. Now, here's one of our heavier patients, and this is quite common, where front part looks pretty good, but we still have at least some of those rolls remaining in the armpit area. And in this particular person, I took the scar, you can't see it here, took the scar to the back of the armpit and took out a lot of the roll, but he still got a little bit of roll there. And he was very happy. It's such a huge difference, obviously, but you know, plastic surgeons are perfectionists, and I'd like for that roll to be a little bit better. But at his current weight, very, very difficult to do. All right, when you ever talk about surgeries, you have to talk about the risk of complications, and top surgeries are no different than any other. There are some risks. Our infection rate so far has been just a tad over 1%, which is nice. I would prefer 0, but been pretty low. Bleeding, not life-threatening, but what's called a hematoma, was an issue up until several years ago. And this is commonly reported in a lot, if not most of the centers doing a lot of these operations. Hematoma means that in the first day or 2 after surgery, when breast swells up because there's some blood trapped in there that the drain can't get out. It's not life-threatening, but it hurts, and it can put pressure on the overlying skin or the nipple graft and jeopardize their survival. And so when people used to get these, we'd get them back in, put them back to sleep for a little while, and clear this out and get it all nice and dry again. And I'll come back to hematoma in a minute, because it's something that, you know, 9% is a lot. That's 1 person out of 11. By contrast, for reconstructive operations overall, the quote unquote normal hematoma rate is about 2%. So this was high compared to pretty much any other surgery we do. You know, we got thinking about that a little bit, as well we should have. But anyway, to sort of finish out here, have not seen a nipple loss. It is a risk. We've seen some partial nipple losses where the edge came off as a scab and healed in. Those do fine. You will sometimes see some peeling of the outer layers of skin in the nipple grafts, but then what's underneath is healthy skin, and it heals up and does fine. But we've been very fortunate on nipple loss, because that's something you hear about a lot, or at least I do. Loss of pigmentation, 4% overall, but again, in patients of color, especially African-American patients, I probably see it in 1/4 to 1/3 of individuals. Revision rates. I'd probably come back and do a little touching up in about 1 out of 10 patients. Usually it's the heavier patients where they want me to try to take out a little bit more of the roll that I could not do at the time of the original operation, because I can't really pull them up in the air or flip them over on their sides to get at it. But some people do come back to clinic and will numb up a little area back there and take out a little bit more of that roll. Fortunately, we can do these in clinic without charging people. I have not had, knock on wood, a trip back to surgery for a revision. I revised some of these that were done in other places. But the 10% revision rate here is all in clinic, local anesthesia kind of touch-ups that we can do without billing people, which is good. All right, hematomas. So when you look in the surgery journals, rates up to 15% have been reported for this after masculinizing top surgery, which is extraordinarily high. And so, as I mentioned, we got thinking about this, and we'd like to get that rate down to at least the range of most other surgeries. It turns out on further investigation that high-dose testosterone, which a number of our clientele are on who are coming in for mastectomy, high-dose testosterone is a little bit of a blood thinner, at least in laboratory studies. The clinical studies have not reported a significant difference, but these are small studies without a lot of patients. So good studies in human beings don't really exist, but at least in the laboratory setting, testosterone does do a number on blood clotting. And so up until 3 years ago, we would not have people stop their T before surgery. Once we got thinking about this, we decided, okay, let's stop testosterone 3 weeks before surgery and not resume until 1 week post-op. So that's a month off of T. Now, do people sometimes get a little spotting? Yeah, they do. Do they get a little dysphoric, a little down the dumps sometimes? Yeah, they do. On the other hand, since we made this change, it's been almost 3 years now. And I'm going to jinx myself by saying this, but we have not seen a single hematoma. Now, we also made some other changes too. We spend more time washing everything out and looking for little bitty bleeders. We wrap people up snug with an ACE wrap afterwards. But I really think that the testosterone change was what made the difference for us. And I totally realize that a number of surgeons, including some of my partners, do not stop the T beforehand. On the other hand, I really like not having had a hematoma, not having to take anybody back to surgery for this for almost 3 years now. So my intention is to stick with this program because it has worked really well for us. But that doesn't necessarily mean that someone who doesn't stop it is doing the wrong thing. It's just, you will find if you talk to more than one plastic surgeon that all of us do things in different ways from each other. And whatever works for that surgeon is what he or she ought to do. This is what works for me. All right, how are we doing on time here, Lou? Okay, I need to mosey on along here a little bit. Okay, second category of top surgeries, feminizing, namely breast augmentation or breast enlargement. Less commonly performed, as I mentioned earlier, than gender mastectomies because people often do get some breast development with estrogens. And also, it's less likely to be covered by payers, even in this day and age. If you're taking estrogens, it's best to be on those for 12 months to see how much breast development you get on the hormones. So for those trans females, 8% have had augmentation. About a third of them would like to have it someday. Not as highly sought after as masculinizing top surgery, but still something that a lot of people want. All right, with breast implant operations, breast augmentation, there are a bunch of decisions that need to be made. As you probably know, there are saline or saltwater filled implants, and there are also silicone gel filled implants. As far as the incisions used for this surgery, you can go around the nipple, you can go through the armpit, you can go in the fold under the breast, periareolar, transaxillary, or inframammary fold. Pocket location, well, you can put the implant in front of the pectoral muscle, prepectoral. You can put it behind or under the muscle, subpectoral. So implant choices, round or teardrop. They still come in both. Most of us use round implants now because they give the best shape. Teardrops have almost totally gone away because most of those were textured. And as I'll talk about in a minute, textured implants have been associated with a very rare form of lymphoma or cancer called ALCL. And so most of the textured implants and most of the teardrops were textured have gone away. So smooth round implants for most people are the way to go. Saline implants versus silicone gel. Silicone gel looks and feels more natural. Some people would rather have saline because they still have concerns about silicone gel. I get it. We'll talk about that in a minute. So here are the 3 incisions on your left. I generally use the fold underneath the breast, the so-called inframammary fold, because I feel like I get the most control over the pocket and I get the nicest shape. Now, subpectoral versus prepectoral, some people call that subglandular. I do both. It depends on the individual. I will do whichever I think will give us the best shape. Certainly, if you put the implant under the muscle, there's a price to be paid for that as far as what's called an animation deformity, and we'll talk about that in a minute. So I know some surgeons are emotionally attached to either all subpectoral or all prepectoral. I sort of look at patients on a case-by-case basis and talk with them about what I think is going to give the best shape. These operations, although technically fairly straightforward, can be a little challenging. How do you figure out what's the best size? I actually size people beforehand, have them come to the pre-op clinic with the size bra they want to fill out. And we have sizers, and the nurse or PA will stand them in front of the mirror and hand them sizers until they fill the bra out the way they want. We write that implant volume down, and that is what we put in. And that tends to make people fairly satisfied with their shape. As far as positioning the implant or where you put the pocket, cis male nipples, as you probably know, are located fairly far to the outside. In trans females, you can't really move the nipple when you do breast augmentation. And yet you'd like to get some cleavage, and yet you would like to center the nipple on the breast mound. And so you can shift the implants more towards the midline to get cleavage, but if you do it too much, the nipple is going to be on the outside of the breast, and that is not a good look for most people. So ultimately you have to kind of compromise. You get some cleavage without having the nipple displaced on the breast mound. And that doesn't sound easy, and it's probably a little harder than it sounds. So here's an example of where we compromised a little bit. And so pre-op on the left, obviously post-op on the right. Some cleavage, but not a whole lot. Nipples may be a little bit displaced to the outside of the breast mound, but not unnaturally so. So this is an example of how we kind of compromise. We get a little bit of cleavage. We try to get the nipples still looking natural in the breast mound, but they're displaced laterally just a tad in this trans female. Okay, logistics. 2 hours worth of surgery, again, going to sleep for that. We do these outpatient. We don't use drains. People like that. Restrictions after this one, exactly the same as the restrictions after masculinizing top surgery. People tend to go back to work a little sooner after this operation because it's not quite as extensive as the mastectomies, but still nothing to sneeze at. And believe me, you don't want to overdo after this operation because you don't want to displace the implant into a less aesthetic, cosmetic location. And you can do it if you overuse those pecs. Risks. Infection rates on these are probably 2%. Hematomas, 2%, 1 out of 50. Implant malposition, rare, but you do see it, especially with the implant slipping too low, something called bottoming out. It's unusual, but you do see it. Again, symmetry is never perfect. I have not had to go back and reoperate on somebody for significant asymmetry, but it is a possibility. Now, animation, movement deformity with implants under the muscle, under the pec. And so the reason we put some of them under the pec, especially in really thin people, is we don't want to step off at the upper pole of the breast between the chest wall and the implant. It looks unnatural. It looks, if you'll forgive me, fake. And so if you put the implant under the pectoral muscle, it gives you a more natural, gradual takeoff below the collarbone from the chest wall down onto the breast. And so that's good. And again, this is mainly in thin people. The downside to that is, though, that when people contract their pecs, you can see some depression, some pushing in of the upper pole of the breast. The fancy term is an animation deformity. It's not ideal, but it's the price that we pay to get that padding over the upper pole of the breast implant to give a more natural appearance. But if you don't need to put it under the muscle for that more natural appearance, I much prefer putting it in front of the muscle, in other words, pre-pectoral, to avoid the animation deformity. Because especially people with a few more pounds on them, they don't need the pec major, the muscle, for padding. And so why not just leave it where it is? You do see decrease or loss of nipple sensation probably in 10% of cases, 1 out of 10. And then there's the issue of leakage with breast implants, and also scar tissue contracture. Scar tissue contracture we see in 1 out of 10. Leakage, if you live several decades, you will probably see a leak. These are not lifetime devices. And if you're thinking about breast implants, the best place to go for information on the implants themselves is actually the FDA's website. They have a lot of good information, and I would definitely read all of that before you have a breast implant. And so if you live long enough, you're going to have a leak. Is it a disaster? No. Does it take more surgery to replace the implant? Yes. We don't go back and replace the implants every 10 years, 12 years, because most of them will survive longer than that, but we do monitor them for leakage. For saline implants, the only monitoring that's required is your eyeballs, because if they leak, they just go down. Your body absorbs the saline. If you have a silicone gel implant, you want to get an MRI scan every 3 or 4 years to check for leakage. So that's that. Gosh, silicone gel breast implants are a favorite topic for the news services. I mentioned this rare cancer ALCL that's been reported in several hundred cases out of several million women with textured implants. For that reason, the textured implants have been taken off the market by the FDA. We have not used a textured implant at the University of Michigan in over 20 years. Didn't like them for other reasons. You'll also, if I can advance the slide, there we go. You also hear about something called breast implant illness. Some patients with breast implants have reported a number of different symptoms, pretty much anything you can imagine, and attribute these symptoms to their implants. It may actually be valid in some people. We don't know, although it's been thoroughly studied. There has not been a study that's shown a connection between breast implants and especially autoimmune diseases, but this array of symptoms have been reported by the minority of women with breast implants, but some of these are very compelling stories. And so we and others are in the process of doing research to look at the possibility that breast implant illness is real. I think if it is real, it's going to be in a very small minority of patients who had other predisposing factors. But still, read the website. You'll see that this is something that is currently under investigation. The bottom line is the vast majority of people who have breast implants do well and are glad they had them. Let's see. And again, to differentiate this from local complications, leakage, scar tissue contracture, infection. That's not what we're talking about here. These are more systemic complaints, fatigue, brain fog, dizziness, muscle aches, pretty much everything you can imagine. And if you go on the internet, just randomly choose websites, you'll come across some of these stories. But this is the best place to go for evidence-based, objective information on breast implants. And in the name of full disclosure, I'm a consultant for the FDA. All right. On behalf of all of us at the University of Michigan Comprehensive Gender Services Program, I appreciate the opportunity to talk about what I do. I love what I do, and I love to talk about it, as you can tell. For more information on our program, feel free to go to the website. I'm going to leave that up for a second for anybody who wants to write it down. All the people seeking consultation for surgery first need to get in touch with the CGSP, and they help arrange referral letters and all those good things. I'm happy to see people who don't have the referral letters yet. I just want them to go through the CGSP first because they actually schedule the appointments for us. But feel free to give us a call if you're in the Midwest or I guess any other place. So these are the 5 of us who do gender affirming surgeries at the university. Jess Sue and I and Bob Gilman do the top surgeries. Bill Kuzan is our guy doing bottom surgeries. Paul Sederna does some of the facial surgery, as does Dr. Gilman, especially facial feminization. And so Dr. Sederna will do a top surgery now and then as well. So there are a number of us here doing these operations. So once again, thank you. And Lou, if we have time, I'd be happy to field any questions that the people have.
Okay, thank you so much, Dr. Wilkins. We
My
do
pleasure.
have some questions, so I will get to those now. The first one is, can you get breast augmentation surgery without being on estrogen?
Yes. Yes, the thing about estrogen is that if you're taking estrogen, you ought to give it a year to work. If you're not doing estrogen, then it's a non-issue.
All right, thank you. The next question is the restriction on driving post-op. I can't figure out why so long.
Yeah, the short answer is I've had really bad experience with that in the past. The longer answer is pulling on steering wheels and doing all the other things with your arms that is required for driving. And mastectomies can give you seromas or fluid collections. In breast augmentation, breast enlargement, it may shift your implant into a less than ideal position. So, yep, you will need a chauffeur for 3 weeks. Sorry about that.
Okay, it looks like the next question is, do you use fat transfer in transfeminine breast augmentation?
Yeah, I figured I was going to get that question. It's a good question. I have not used it for feminizing breast surgery. I have used it for other types of breast surgeries. You certainly could in this setting. There are some things to bear in mind, though. One is that it usually requires more than one surgery. At most, you can put in probably 150 cc's or so. How many ounces? 5 ounces, maybe 5 or 6 ounces at a time per surgery. And so for those who haven't heard of this, we actually liposuction fat out of hips, thighs, flanks, wherever people have fat. We spin it down to get the viable fat cells and then pour the fat cells in a syringe, make a couple little needle sticks in the breast, and bit by bit, really 1 cc or 2 cc's at a time, lay rows of fat into the breast tissue to gradually enlarge that space. We can only do so much at a time because if you put in too much and you start getting pools of this fat, that fat will die, it will not take, it will not survive. It gets replaced by scar tissue and becomes this big lump or mass that usually needs to be taken out. And so you don't want to go too fast or do too much, meaning that if people need more than maybe a cup size increase in volume, they're going to need more than 1 episode of this, and you need to wait 3 to 6 months between episodes. And there's about 4 weeks of restrictions after each of those surgeries. Plus the liposuction site gets pretty bruised up and is right touchy for a while. And so I don't think it's a bad thing to do, but it is more of a process, obviously, more than 1 surgery compared to breast implant. But then with fat grafting, you don't have to worry about leakage or that kind of thing. So, I mean, there are pros and cons either way. And frankly, if the right candidate walked in the door to my clinic tomorrow, I would probably do it.
All right, thank you for that answer. If anyone else has questions, put them in the chat. Otherwise, I have a couple I'm gonna ask. And I also just put the feedback form into the chat. If you all could please fill that out. It's just a few questions. It's not very long. So I know you mentioned that people younger than 18 are wanting top surgeries, and I guess I'm just wondering, are there more complications from that, or do their breasts have to be like fully formed before you can do top surgery? Yeah, can you talk a little bit about that?
Well, my experience in the under 18 population has been almost exclusively, well, has been exclusively with masculinizing top surgery. Now, if someone under 18 was looking for feminizing top surgery, and they're either not on estrogens or they've been on estrogens for a year, you know, my criteria for operating on them would not be any different. At least with the masculinizing surgeries in the under 18 folks, the complications rates have not been higher. The biggest issue is that there aren't many insurance companies that will cover the surgery in that population. And so I've got several patients now, you know, counting the hours until their 18th birthday so they can have the surgery and not have to pay out of pocket. But, you know, for teens, to be honest, I'm probably overgeneralizing. I think it's a great idea. You know, if you know who and what you are, and you know your body doesn't fit, you know, doing it earlier in the teenage years. I mean, teenage years are tough anyway, but for trans teenagers, it's harder. And so, getting people the bodies that fit with who and what they are earlier, I can't imagine how that's a bad idea. I mean, people still need to go through the same process. Somebody who's, you know, better trained and more knowledgeable than I needs to sit down and talk to them and have an ongoing relationship with them to make sure that we're doing, in a therapeutic sense, make sure we're doing the right thing. But, you know, once they appear in my clinic, you know, they've been through the system and they've met with their social worker or whoever, sometimes multiple social workers, and they have the referral letters and they're deemed acceptable candidates. And, you know, I'm tickled to death to see the under 18 folks because, you know, they're suffering. And if this helps, and I think it does, you know, this is something we should be doing.
Great. Yeah, thank you for that answer. So we are right at 2 p.m. Eastern. So I think that will be the last question. I just want to thank Dr. Wilkins for being here and making this presentation today. There was some very valuable information presented, and thank you to everyone who attended today. As I mentioned earlier, this session is being recorded, so anyone who did register who wasn't able to make it today will be able to see this later. Yeah, so I think that's it. Just another reminder, the feedback survey is in the chat, so if you could fill that out, that would be great.
All right, well, Lou, thank you, and thank you everyone else. And I appreciate you letting me talk about something I love. Have a great day, everybody.
Yes, thanks everyone.